Well, welcome everybody to the next in our line of COVID-19, like the science of COVID-19 webinars. Today we're going to talk about the treatment of COVID-19, and we've got three fantastic speakers talking about some different drugs that are already available that may be able to treat symptoms of coronavirus. So I'm just going to quickly do an intro. My name's Scott Colborne. If you don't know me, I'm the chair of the pharmaceutical group within the RSCI in New South Wales, and just going to try and host and moderate this session. The format today, we've got three speakers. They'll all speak in turn. You know, we might take the odd question after each talk as they come through. If not, we'll do an open Q&A at the end. It's 90 minutes in total. So we'll see how we go with all that. It will be recorded at the end, and that will be posted in a week or two once we've just organized it all and everything at the end. In terms of posting questions, there's going to be no audio or anything. So if you could use the Q&A function. So in the Zoom window down the bottom, you'll see Q&A. If you click on that, you can ask a question. Questions, you can say who you are, or you can make it anonymous. We'll answer them live, or there'll be typed answers and everybody will be able to see the answered questions. So please use that Q&A function down the bottom. If there's something outside of an actual question, use the chat function if you've got anything you'd like to ask me as we're going through everything. So today we have Natalie. We'll be talking about Interferon-beta. Natalie is a senior hospital pharmacist, specializing in antimicrobial stewardship. Extensive experience in clinical services across various things like medical, surgical specialties, all that stuff. You know, also an active member of the COVID working group, working party, I should say, for the management of COVID-19 at Bankstown Hospital. Second will be Renee talking about Dexamethasone. Renee worked as a community pharmacist first for a number of years before joining the pharmaceutical industry in regulatory affairs. Her senior regulatory affairs role now involves working closely with the TGA, registering new medicines in Australia. Renee is also a pharmacist educator and occasional lecturer at the University of Sydney. Then lastly will be Jan-Willem, Remdesimir, he will be talking about. And Jan-Willem is a hospital pharmacist and clinical pharmacologist. His research aims to optimize antimicrobial therapy, trained in the Netherlands, Groningen, I'm going to get that badly wrong, I know I am. He's been a principal investigator of many clinical trials studying pharmacokinetics of antimicrobial drugs and participates in several international consortia. So there are three speakers for today. And what I'll do is I'll shut up now, and I'm going to get Natalie to put a presentation on the screen and get us going.
Okay, just sharing my screen. So
no worries.
With me. Okay, you
That's
can all
perfect.
hear me okay?
That's perfect.
Yep.
Perfect.
Okay, so good afternoon, everybody. My name is Natalie Kahwajy. Thank you, Scott, for the introduction. We'll be talking today about the role of interferon-beta in the treatment of COVID-19. I think everyone would agree that it would be an understatement to say that this year has proven to be quite an interesting one for everybody. Globally, as of yesterday, there have been more than 33.5 million confirmed cases of COVID-19, including more than 1 million deaths that have been reported to the World Health Organization. So severe acute respiratory distress syndrome, coronavirus 2, or SARS-CoV-2, or coronavirus disease, or COVID-19, or whatever you'd like to call it, has almost been a year ago now since it was originated in Wuhan in China in December of 2019. And of course, as the name suggests, it is a virus. The majority of the patients who would be infected with this virus experience mild to moderate symptoms, which generally includes flu-like symptoms. And that includes obviously sore throat, a cough, a fever, shortness of breath. And the majority of these patients generally do recover alone without any special therapy or treatment, and also without really needing to be admitted into hospital. However, a small percentage, 5 to 10% of patients who are infected with the virus, especially those vulnerable patients, so those who are elderly and with existing comorbidities such as cardiovascular disease like diabetes or respiratory conditions such as asthma or COPD, they do have a high risk of progressing to the severe form of the disease, which does require hospital admission, and they have that high risk of essentially respiratory failure and death. As everybody is already aware, of course, coronavirus is spread through saliva and fluid droplets that are released from an infected person's nose or mouth when they cough or sneeze. And at the moment, there are no current registered drugs that are available to treat COVID-19. Hence why we live in the current world of hand sanitizing and hand washing and masks and social distancing. So for that purpose, the scientific community has shifted their focus to try and focus on the repurposing of existing drugs that we know have antiviral properties. And the focus of treating COVID at the moment is really through supportive care and the management of associated complications. So that brings me into talking about the potential for interferon-beta, as it is one of those therapies that is currently under investigation for the treatment of COVID-19. So what are interferons? They belong to the cytokine family, which are a group of naturally occurring proteins in the body. There are three main classes of interferons, so that's interferon alpha, beta, and gamma. Interferon alpha and beta are part of type 1 interferons, and of course, interferon beta is the one we're focusing on today. Interferon beta is released by many cell types in the body in response to an infection, particularly a virus infection, and that includes cells such as macrophages and fibroblasts. And essentially, interferons, it's one of the first cytokines that are produced in response to a virus being introduced into the host. And as the name suggests, they have the ability to interfere with viral proliferation, and they have antiviral, antiproliferative, and immunomodulatory effects. Interferon beta in particular, it does exist as interferon beta 1A and 1B currently on the market. And that is indicated for relapsing forms of multiple sclerosis or MS, as well as in the first demyelinating event suggestive of multiple sclerosis. So just a quick recap to understand what multiple sclerosis is and how interferon beta can actually aid in the symptoms of this disease. Multiple sclerosis is a chronic, debilitating autoimmune condition that does affect our central nervous system. And it's pretty much when our immune system dysfunctions and starts attacking itself, particularly the myelin, which is the fatty sheath layer that usually insulates our nerves, and therefore causing these lesions that you can see here that not only interfere with nerve signaling, but eventually can block nerve signaling, particularly for the nerves that affect the muscle. And so that then becomes manifested in those symptoms that we find are clear in patients with multiple sclerosis, which include things like muscle weakness, cramping, difficulty swallowing, lack of coordination, and in the more severe form of the disease, eventually limb paralysis. The exact mechanism by which interferon beta actually works to treat multiple sclerosis is not very well understood, but it is thought to act through immunomodulatory effects, which essentially it's kind of mostly reducing how much cytokines are being produced, and that reduces in turn inflammation, and it basically dampens down that dysfunctioning immune response that occurs in patients with multiple sclerosis. But how does interferon beta specifically exert its activity as an antivirus, for basically increasing its potential for the treatment of COVID? It does that through the JAK-STAT signaling pathway. So when a virus is introduced into the body, interferon beta is released as part of the natural host defense mechanism, and they travel around whereby they basically get recognized by their receptor, which is the interferon IFNAR receptor. And upon binding, binding activates or stimulates two members of the JAK family, which are kinases. And these kinases then, as their name suggests, they phosphorylate and they go and they bind to the STAT molecules, and that stands for signal transducers and activators of transcription. And once that becomes phosphorylated, then that becomes active and it forms a dimer, which will then translocate inside the nucleus of the cell that will go and bind to upstream regulatory regions of interferon sensitive genes, that will then go and regulate the expression of interferon stimulated response elements. And these are the things that eventually cause reduce the cytokine release, and a lot of the time it's been shown to reduce a cytokine storm that is said to be associated with patients who have a critical form of COVID-19. And so that reduces inflammation. And I guess, that's how it helps with both, I guess, COVID symptoms, which we'll find out very soon, but also in multiple sclerosis. And what has been shown so far is that essentially coronavirus appears to have had or to have developed this strategy that is able to, I guess, turn this system off in our body and overcome it. So there was an immune analysis on 50 patients that was conducted recently with varying forms of the disease, mild, moderate, severe, and critical. And they actually observed a unique phenotype that was associated with patients who developed a severe or critical form of the disease. So what they observed was a highly impaired interferon response, as well as a significantly lower serum concentrations of interferon, which basically meant that there was a lot more inflammation around in those patients in the severe and critical form of the disease. They also found a low interferon response actually preceded somebody to clinically deteriorate to the critical form of the disease. Another in-depth analysis that was conducted also showed that patients who did have the virus, as well as in cell and animal models, there were low levels of type 1 and type 3 interferons. And interferon-beta is part of type 1 interferons that was also linked to augmented inflammation in these cells, and that was also to do with interleukin-6 levels. Sorry, just one moment. I think my dad just... So there was another study that was also conducted that basically showed particular proteins that coronavirus produce, including the ORF6 and ORF8, were potential inhibitors of type 1 interferon signaling pathway, which basically, does include interferon-beta. And so the Journal of Infectious Diseases published this particular paper that suggested that if you give cells that are infected with coronavirus in vitro interferon-beta 1A, that was shown to be highly effective in inhibiting the virus's replication at clinically achievable concentrations when administered after the virus infection. And so what has been observed so far on patients, besides in vitro studies, that we could take from today in terms of how effective interferon-beta is in the treatment of COVID-19? So a randomized control trial, and I've picked kind of the major ones that I thought would be of great benefits to discuss today, and the ones that have shown, a bit of valuable findings. This randomized control trial was conducted to look at the efficacy and the safety of interferon-beta in the treatment of severe COVID. So they recruited 92 patients, and 42 patients were part of the treatment group, whereby they received subcut interferon-beta 3 times a week for 2 consecutive weeks, plus the national protocol medications, which included hydroxychloroquine, as well as either Kaletra or another antiviral medication. So the control group obviously received just the national protocol medications without subcut interferon. They looked at multiple outcome measures. The primary outcome measure was the time to reach clinical response, and the secondary outcome measure was the duration of hospital stay, length of ICU stay. They looked at 28-day mortality, as well as whether it made a difference to give interferon-beta either early on or later on during the virus. And the definition of an early administration was giving interferon-beta within 7 to 10 days from the onset of symptoms. So what they found was that there's no statistical significance in the time to achieving a clinical response. However, they found that a higher percentage of patients who did receive interferon-beta, they could be discharged from hospital versus the control group who did not receive interferon. This was an interesting study because it was the only one that I could find that actually showed a statistical significance in the mortality overall. So they found that the 28-day overall mortality was actually significantly lower in patients who received interferon-beta than those that were in the control group. And they also found that if you gave interferon-beta within the first 7 to 10 days of the infection, it actually significantly reduced mortality. So I guess watch this space with this one, because I don't know how it's probably not the most reliable result, but it is a very interesting one. As I said, it's the only one that, only study that I've really reviewed that showed that there was a difference in mortality rate. This other randomized phase 2 trial looked at the effectiveness of a triple combination of interferon-beta, as well as Kaletra and ribavirin. So they recruited 127 patients. 86 patients were in the treatment group, whereby they received a combination of Kelettra, ribavirin, and 3 doses of subcut interferon-beta on alternate days. They looked at the primary outcome measure of time to achieving a negative COVID swab, and secondary outcome measures, which included time to symptom resolution, length of hospital stay, and the 30-day mortality. So the treatment group, just checking if there's any questions that are coming up, but I might just leave that till the end. So they found that patients who were in the treatment group that received interferon-beta had a significantly shorter median time to achieving a negative swab. So they were able to show a statistical significance in their primary outcome measure. And they also saw that the treatment group who received interferon-beta significantly had better clinical outcomes in the sense that they could achieve symptom resolution a lot quicker. There was a shorter median hospital stay for those who received interferon-beta, although that was not statistically significant. And an analysis of the serum cytokine profile showed that patients who did receive interferon-beta also had a significantly lower levels of interleukin-6, which essentially is also related to less inflammation in the body, therefore less likely to develop respiratory failure, and patients will be able to breathe a lot better. So no difference in mortality, as no patients thankfully died during the study. Another clinical trial looked at interferon-beta in the treatment of severe COVID. 80 patients were recruited, and the treatment group received 250 micrograms of subcut interferon-beta on alternate days for 2 consecutive weeks, plus Kelettra or the other antiviral, plus hydroxychloroquine. The control group did not receive interferon-beta, just received the other medications. The primary outcome measure included time to clinical improvement, and secondary outcome measures included in-hospital complications, as well as a 28-day mortality. So they found that time to clinical improvement was significantly lower in the treatment group receiving interferon-beta. They saw that people in the control group who did not receive interferon-beta were more likely to be admitted into ICU. There was no statistically significant difference in the length of hospital stay and in the length of ICU stay between the 2 groups. And there was no statistical significance in the all-cause 28-day mortality rate, although patients who did receive interferon-beta, the mortality rate was lower for those. So whilst we're discussing interferon-beta and the clinical trials that have so far been done and concluded, you know, is it really safe? What are some sort of its adverse effects? Now, a lot of these papers that I've just discussed, there's not a lot of, I guess, discussion in regards to the adverse effects. It seemed to be interferon-beta to be quite overly safe. But of course, it is something that is available on the market for the treatment of multiple sclerosis. And the dosing that you would see for these clinical trials that would look into interferon-beta in COVID is a bit different to what's currently established and indicated for multiple sclerosis. So far it appears to be safe, but there are, and we'll see in the rest of my presentation, there are some, of course, trials that are looking into its safety. But what we know so far about it is that straight from the AMH, the Australian Medicine's Handbook, it does have a few precautions that we need to be very mindful of. So that does include things like it has an increased risk of depression and suicidal ideation. So it is a precaution for us to utilize interferon-beta in somebody who has an existing mental illness. It does reduce seizure threshold, so that is also something to watch out for. And interestingly, it can also worsen the cardiac disease, which includes heart failure. And a lot of the patients who would, I guess, progress to the critical or the severe form of COVID, who would require potentially interferon-beta, they do tend to be those more vulnerable patients who have existing comorbidities, including cardiovascular disease. So that's something to kind of consider and be very mindful of. Other adverse effects include just the common flu-like symptoms, as well as just some raised LFTs. But more of the rare adverse effects include more serious ones, including thrombocytopenia and blood dyscrasias and so on. So whilst I've just discussed some of the clinical trials that have had they've concluded and they've shown some results, what about the current, trials that are currently occurring that we still don't have results for, but just for us to kind of watch the space? So there is this clinical trial that is occurring in Hong Kong that is recruiting different patients from basically 6 hospitals in Hong Kong. It's an open label randomized control trial looking at interferon-beta 1b and ribavirin for the treatment of COVID-19. They are reviewing and evaluating the effectiveness of a short course of interferon-beta and ribavirin combination for patients who are in hospital and who have COVID. And they'll be randomly assigned, and they have already been randomly assigned to the treatment group, which would receive a 5-day course of subcut injection of interferon-beta and ribavirin as well as supportive care, or the control group, which is just supportive care. Some of the primary outcome measures that they'll be looking at include clinical symptom alleviation and resolution. Secondary outcome measures that they'll be looking at include length of hospitalization as well as the time it takes to achieve a negative swab, some inflammatory changes looking at the cytokine level and chemokine levels in the body, a 1-month mortality rate, as well as I mentioned before, any adverse effects and serious adverse effects within 30 days of treatment, particularly with interferon-beta. The National Institute of Allergy and Infectious Diseases also has started an adaptive COVID-19 treatment trial 3, ACTT3, that will be looking at the Remdesimir, which is your third talk for today, plus interferon-beta for the treatment of COVID. So the treatment group will receive a subcut injection of interferon plus Remdesimir. The control group will receive a subcut placebo injection plus Remdesimir. So the primary outcome measures that they'll be looking into would be time to recovery, and that's defined by hospital discharge, and secondary outcome measures, which includes patient outcomes at day 15, as well as comparison and mortality rates. Now, so far we've been discussing subcuts and injection of interferon-beta. However, preliminary studies have shown that, of course, if you give interferon-beta through the pulmonary way, so as an inhalation or a nebule, that has been shown to be quite effective in relieving some symptoms. As there's discussion to say that obviously when you inhale it, it does provide not only a localized effect, but it also obviously helps reducing any of its potential adverse effects that you would get when you are exposing it systemically to the body. So there is this particular study that is being conducted to look at the treatment of interferon-beta as it is as a nebule, and how effective it is for the treatment of COVID. So 60 participants have been recruited, and what they're looking at is the oxygen requirements of those patients with COVID that are in hospital, in terms of how those oxygen requirements would differ, whether the patients receive inhaled interferon or not. So the treatment group will receive nebulized interferon-beta versus inhaled water for injection for the control group. And they're looking at primary outcome measures of the oxygen requirements at different time points. Similarly, Synergen company is the research. They've looking into trialing this SNG001, which is basically an inhaled form of interferon-beta, looking at trialing this drug and looking at its effectiveness in the treatment of COVID. They've recruited 820 patients, and this will be a randomized double-blind placebo controlled clinical trial where the treatment group will receive nebulized interferon-beta versus the control group who will receive just the nebulized placebo. They were looking at the primary outcome measure, which is time to clinical improvement, as well as some secondary outcome measures that include progression to pneumonia, as well as the patient's oxygen levels, the risk of adverse effects, again with interferon-beta, the time to improvement of the symptoms, as well as, of course, looking at the measure of quality of life. And just to give you also an idea of the in-depth analysis that is currently happening in regards to the treatment of COVID, is that there is this also evidence to show that there's trials that are underway looking at the effectiveness of the different subtypes of interferon-beta. So this trial is looking at comparing the effectiveness of interferon-beta 1A as opposed to interferon-beta 1B for the treatment of moderate and severe COVID-19 in patients. So the patients have been divided into 3 different groups, one receiving hydroxychloroquine plus coletra plus interferon-beta 1A, the other receiving hydroxychloroquine plus coletra plus interferon-beta 1B, and the other is just hydroxychloroquine and coletra without interferon. So they'll be looking at, again, time to clinical improvement, which is very common, of course, in a lot of these clinical trials, as well as other secondary outcome measures, which include mortality rate, as well as the length of hospital stay. So I guess some of the key messages that we can take home, and I won't keep you for much longer. So what have we learned so far in terms of interferon-beta in the treatment of COVID-19? Some true or false statements. So we know that eating garlic does not help to prevent COVID-19, although you're welcome to eat as much as you like. We know that interferon-beta does lead and has been shown so far to lead to faster clinical improvement, faster symptom resolution of COVID. It's not only the young and the elderly who can be infected with COVID-19. The elderly are more likely, they are at a higher risk due to their existing comorbidities and their older age, but everybody can be infected, as we, I'm sure, are all aware. Interferon-beta has been shown to reduce the length of hospital stay, although in some studies that was not statistically significant. This is the one I struggle with the most as the antimicrobial stewardship pharmacist, and that is routine use of antibiotics do not need to be used in COVID-19 patients, as it is a virus. Although, of course, when patients do come into hospital and they often, of course, have symptoms that overlap, you know, pneumonia symptoms, CAP, community-acquired pneumonia, and COVID. And I guess until that swab comes back positive or negative, that does warrant the use of antibiotics, but definitely not routinely. And finally, interferon-beta appears to have caused a statistically significant reduction in the 28-day mortality rate, as per that one clinical trial that I discussed earlier, although that is definitely something to, I guess, watch the space for, and just, you know, monitor the progress of those clinical trials that I discussed. And that's it. Thank you very much.
That's wonderful, Natalie. I do have one question that's come through, and it was to do with hydroxychloroquine. I can pronounce that wrong. Is there any comment on why it's included in so many of the studies?
That's a good question, why it's included in so many of the studies. I think initially when COVID, look, I haven't done a lot of research in terms of the effectiveness of hydroxychloroquine, but from what I understand, it's not really been shown to have a bit of an effect as everybody initially thought. Yep. So I think it's just, since it was a big hype was occurring around hydroxychloroquine as soon as COVID-19 was initially introduced, that's probably what's prompted it to be included in quite a lot of the clinical trials, particularly the earlier ones. I think a lot of the later ones are now focusing more on the other medications that have a higher potential. So, yeah.
Yeah, okay, cool. And look, there's a stupid question from myself here. Really, the plan is you would give this to people once they're in hospital? They come back with a positive swab, you wouldn't go and prescribe it from day one. It would be from hospitalizations to...
Yeah.
Okay.
So cool. A lot of these studies are based on patients who are admitted into hospital. And of course, it is, a lot of them talk about a subcut injection. So that I would presume that's not something that everybody would be familiar with, but it's definitely within the hospital setting. And it's, I guess, aimed also at patients who, when they do get into hospital, you presume that they are at a stage of a severe form of the disease, and not just a mild to moderate, because a lot of those patients do recover without any sort of treatment. Yep. So yes, definitely inside the hospital as inpatients. Yep. Yeah,
cool. No, that's great. That's great. Thank you for
that.
Although
I haven't seen it myself in my practice yet, so I guess that's also something that's you know, interesting. We have not had anybody at our hospital and other nearby hospitals that I'm aware of or familiar with to actually actively use interferon-beta. But definitely some of the other medications possibly that we'll be talking about today. So yeah.
Yeah, cool. Well, it's obviously difficult in this country. We don't have many cases, do we? So who do you test it on? You know, so
exactly.
But no, that's great. That's great. So we'll move on to Renee to talk. No, that's great. Thank you. If you'd like to share your screen, Renee.
Yes. Hello. Sorry, I'm holding my microphone a little bit too close to my face to make sure you can all hear me well.
Come through loud and clear. Loud and clear.
Awesome. All right. So hopefully you can also see the presentation.
Perfect.
Let me minimize that one. Awesome. Okay, so as Scott has kindly introduced everybody in the past, my name is Renee. I am a pharmacist graduating from the University of Sydney. I do work in the pharmaceutical industry in the regulatory affairs team, basically working very closely with TGA and MedSafe to register medications and maintain those registrations. So got a very interesting topic for an interesting year, but I'll be discussing dexamethasone for today. So I'm sure you're all familiar with the term a steroid or a hormone in the body, and we've got many, many of them in our bodies. One of those key hormones is cortisol, and a synthetic version of cortisol is actually dexamethasone. It is widely available. It's been around for many, many years. It comes in many presentations in the pharmacy, for example. You see it as tablets, it could be in eye drops, e-drops, etc. And it's on the World Health Organization's essential medicine list since about the 70s, actually. So it's been around for a long time. Its main use its main application, is due to its anti-inflammatory properties. So it is used whenever inflammation may be present for symptoms such as itching, swelling, redness, or pain, for example. And in that bubble that I've got there on the screen, you can see some of the applications that it's used in. So for example, psoriasis, arthritis of the joints, some eye conditions, inflammations of the bowels, some cancers as well. It's used to help diagnose Cushing's syndrome. Can also be used in severe allergies, and I think the two most relevant or similar to the topic that we're discussing today is its application in asthma and respiratory infections. So what normally happens when there's a pathogen that the body's been exposed to? So say, for example, there's a bacteria or a virus. The body's innate reaction is to initiate an inflammatory response. So what happens is there's an increase of blood flow to the affected organ or the affected area. And the reason for that increased blood flow is it brings anti-inflammatory molecules with it. So you can see on there, we've got prostaglandins, we've got cytokines that Natalie has discussed previously, and white blood cells, for example, also known as neutrophils. And this is actually where corticosteroids come in to help. Corticosteroids like dexamethasone. We need, as I was mentioning in the previous slide, it helps to reduce inflammation. And you may be thinking, Renee, how does that make any sense? If we want to fight off this pathogen, why are we using a drug that's actually reducing the immune response? Well, it's a very valid question, to be honest, and I would be wondering the same. But as Natalie also addressed prior to my presentation, with COVID-19, it's been noticed that there is what's called a cytokine storm. So what happens is cytokines are like little messenger molecules, if you like. So they come in when there's that increase of the blood flow, and they go, you know what? We need more of ourselves. We need more neutrophils. We need more prostaglandins and more cytokines. So it ends up being this sort of spiral that keeps attracting more and more inflammatory signals and molecules. And this can actually be very harmful. So this can cause things like organ failure or even the death of the patient. And that's the reason why corticosteroids like dexamethasone are helpful in this instance. We have to remember as well that this doesn't actually stop anybody catching COVID. Just because somebody's taking dexamethasone does not mean they're not getting any virus or bacteria. That's not how it works. It merely limits that inflammatory response in the body. So what data do we have actually up to date or up till now about COVID-19 and corticosteroids? And this is actually quite interesting as I was working on this presentation, because we're constantly getting new data. So every now and then when I come to sit down and put some more information in my presentation and research what's been happening, things have been changing. So by the 24th of June 2020, there were 55 studies globally registered to investigate the impact of corticosteroids in the treatment of COVID-19. And one of them that I'd like to draw your attention to is the recovery trial, because this is probably the most pivotal trial in the treatment of COVID-19 so far relating to steroids. Recovery, basically, it stands for the randomized evaluation of COVID-19 therapy. So it actually started back in March, when we all started our lockdown here in Australia, but it recruited just under 12,000 patients, and 2,500 of them were assigned to dexamethasone. It is in the UK, based at the University of Oxford, randomized in a multi-center study. I do have to point out this dexamethasone in this study was used in hospitalized patients only, and those who needed help breathing. So they either needed oxygen or ventilation. What this study was looking at basically is the primary outcome of the effect on the 28-day mortality. And this was compared to the standard care alone in patients who were in the hospital. I mentioned before that there were just under 12,000 patients, and that's because this study did not actually just look at dexamethasone or corticosteroids. There is a long list of medications that they've looked into, and for the purposes of this presentation, I won't be going into the others. But that's, there's a lot of them. They've published some results already, and the study is still ongoing for the time being. So what they actually used in the study was one of three drugs. The first one, the primary one, was dexamethasone, and that was given 6 milligrams per day, either orally or injection, for up to 10 days, no longer than that. Alternatively, if, say, a patient was allergic to dexamethasone or they were pregnant or breastfeeding, they were instead given two other types of corticosteroids from within the same family. So either methylprednisolone daily or hydrocortisone twice daily. So back in June, they released preliminary results of the outcomes so far. As you can imagine, we're living through a pandemic. Any data that we have, any information that we can gather and we can communicate as soon as possible is incredibly beneficial, because at the end of the day, it's all about saving lives. So preliminary results were released in June, and by then they found that dexamethasone did actually reduce mortality by about a third in those who needed ventilators and a fifth in those needing oxygen. So you can see in the middle of the slide there in the blue text. So that's 1 death prevented for every 8 ventilated patients or every 25 patients needing oxygen. And any life saved is, worth, it's a great milestone. Overall, the reduction of deaths by using dexamethasone was 17%. So obviously very, very promising results. And this actually led to some other trials to stop what they were doing and straight away put their patients on dexamethasone. The production of the drug at the time also went up, it just escalated, trying to get as many people who are eligible for it as possible. However, at the time, as you can appreciate, we had this one study telling us these great results, but doctors were still a little bit reluctant to go ahead with prescribing this medication because it's a short result, results were available very quickly, and it wasn't peer reviewed at the time. However, in that blue bubble at the bottom as well, the World Health Organization released a statement to say that this is the first treatment to be shown to reduce mortality in patients with COVID-19 requiring oxygen or ventilator support. As mentioned earlier, so the trial is still underway. What's happening is whenever they have promising results like dexamethasone, for example, in this scenario, they refine their study to, look into different aspects of using it or different dose forms, and other treatments that have shown to be unsuccessful are being withdrawn from the study. So any new data that we have on new medications that can be repurposed or coming to market can be included in this study. There is no benefit, I should mention, however, of using this drug in patients who are not hospitalized. This is one of the things that the study actually found. And the World Health Organization at the time realized the reluctancy among some practitioners to actually go ahead with prescribing this medicine for whatever reason. So in order to add value to the study, in order to strengthen the results of this study and build on the data that we currently had, they decided to undertake a meta-analysis of corticosteroid treatments with COVID-19. So the meta-analysis was called the Association between the Administration of Systemic Corticosteroids and Mortality among Critically Ill Patients with COVID-19. And this was actually just released just short of a month ago. It looked at 7 studies. I know you may be wondering, Renee, initially you stated that there were 55 studies. Why were only 7 included in this meta-analysis? As you may be aware, for a large number of reasons, a lot of studies often stop sometime during the duration of study, whether it be lack of funding, whether it be participant dropping out, for example, or some just weren't eligible to be included in this meta-analysis based on the criteria that they had. So 7 studies, just over 1,700 patients, and this was looking at results between February and June of this year. There are actually 12 countries included, so it gives a good indication of the patient profile. Sometimes we know we can have interracial differences between different individuals, and we can actually feel proud that we contributed to this study. Results were taken from Australia and New Zealand, and it did also address or look at basically patients who were severely ill. So again, those needing that help with their breathing. One last thing to mention about this meta-analysis as well in terms of its design is that it did look at those 3 drugs, so dexamethasone, hydrocortisone, and methylprednisolone. So we do actually have the results published in the Journal of American Medicine, And the primary outcome was the same as that of the recovery trials, which is the 28-day mortality. But it did also look at the serious adverse events of using those 3 corticosteroids. Now, the results, basically, again, very, very promising. So we've got, in comparison to patients who were given standard care, corticosteroid deaths were at 33% compared to the usual practice of managing COVID, which was 41%. So again, it does help to save lives, but it is for those patients that are critically ill. It also, this figure also does not differentiate between patients who needed oxygen or mechanical ventilation. It's applicable to both. And the results do not just apply to dexamethasone. So the same result can be seen with using methylprednisolone or hydrocortisone. So basically, the results of this meta-analysis actually confirmed what the recovery trial had shown back in June, which is very, very, very great evidence. Looking at the secondary outcomes, so looking at the side effects of dexamethasone, I mentioned at the beginning of the presentation that it was for a 10-day period, up to 10 days of using corticosteroids. And because it's such a short treatment, there were no serious side effects expected or seen. And that's very common with corticosteroids. That's most of the time in practice in pharmacy and hospital use, that's prescribed for that short period of time. The longer term side effects of corticosteroids that often that sometimes worry some individuals do not actually apply in this case because of that short treatment. The only possible side effect that wasn't seen to happen often, but I guess in more susceptible patients or patients who have trouble managing their blood sugar, could be hyperglycemia. But again, this is very short in duration, and the patient and their doctors are aware of the patient profile and can work to sort of minimize that happening. There was a concern also in the study for potential lowered immunity and hence bacterial pneumonia occurring. However, this wasn't a major concern. All right, so where to now? So the World Health Organization are actually in the process of updating the treatment guidelines to include steroids in those guidelines. And I found it quite interesting in that we actually had those in Australia already. We were actually using or recommending dexamethasone, based on the patient criteria and helping to manage COVID-19. So we'll be great. We'll be aligned with the World Health Organization. Again, any of the 3 can be used depending on, again, pregnancy, breastfeeding, allergies, etc. And the great thing about this drug is we're actually repurposing it. It's not something that's brand new, like the vaccine, for example, that's coming out. It's a drug that's been around for a long time. We have a lot of data for it. We know about its side effects. We know about the patient groups that it can be used in. And because of that, it can actually be used in children and the elderly. And as Natalie mentioned, they tend to be the most susceptible people during this pandemic. In terms of some drawbacks of this meta-analysis, or I guess just using this drug in general, we have to remember that it's not a cure. It's not going to prevent getting the illness. It's not going to treat it. It's simply going to help with the symptoms. And as we've just realized, going to save lives as well in those critically ill. We are lacking data, however, for those who have mild symptoms. So often, most patients, they can just stay home and isolate, and their COVID can be managed outside of hospital. So we don't have enough data for those patients. What will dexamethasone or corticosteroids have beneficial for them? And finally, the great result, I guess, of the recovery trial and the meta-analysis is that the risk-benefit is favorable. So there's no harm, if any, in using corticosteroids in patients who do require and qualify for its use. We do realize that patients and, a lot of patients could be on different medications. Not everybody may actually have, it depends on the medications that people are taking. So dexamethasone is a CYP3A4 inducer, which is an enzyme in the body. There are medications that actually interfere with this enzyme. Sometimes there are foods that interfere with this enzyme as well. So the medications that a patient may be on need to be considered in order to figure out if dexamethasone or another corticosteroid may be the best medication to use in this instance. And the thing that we have to remember as well is that the duration for use it's short. It has to remain short in order to prevent the longer term side effects. And one of the things that I guess one of the things that can happen from hindering the immune system for a long time is the reactivation or an increase in the reactivation of latent infections, such as hepatitis B or tuberculosis. Again, to reiterate, this is not a problem in this scenario because the guidelines specify that the use is to be short, no longer than 10 days. And that brings us to the end of my presentation. So thank you very much. Are there any questions?
Yeah, there's a couple of questions we've got there, Renee, we can go through quickly. So you mentioned about children, elderly. I think you mentioned pregnancy. So sorry, we can or can't use corticosteroids if you're pregnant? You
can, not dexamethasone. You can use methylprednisolone or hydrocortisone.
So do they all show the same effect, really, if you know what I mean? There's not a lot of difference. Is that what you're saying from the trials, from those?
So the trials were focusing on dexamethasone. I think that had probably the best profile to investigate in this study, but because of its, I guess, it's not really it's not recommended to use in pregnancy and breastfeeding. Hence, the other drugs were included in the study. And in terms of results, any of the three can be used. All three have you know, the same efficacy, and they all help to reduce patient deaths.
Excellent, excellent. The only other question I had quickly was, actually, no, I don't have it. You've already answered it. It was about typical side effects. You've already talked about those, so that's cool. So no, there's nothing else at the moment, but I'm sure we'll get some through. No, that's great. That's great. We'll move on to Jan-Willem, and then we'll do some more questions at the end. Thank you, Renee.
Thank you.
Yes, I'm unmuted. That's good.
Oh, that's cool. Have you? Yeah, perfect. That's excellent.
Okay, thank you for the opportunity to talk about an exciting, and we will see whether this will be the drug to treat COVID-19. So we already wrote a little bit about the disease and what's happening and how sick you can get due to all the inflammatory responses. So immediately when people started recognizing this disease, they started searching for potential treatments. And what normally happens is they go through the laboratories through the assessment of available drugs. So already rapidly a whole pattern of different drugs for the different steps in the viral replication cycle were studied, as well as Remdesimir. And this is not a new drug, it's actually a repurposed drug, although it has not entered the market yet. So it's already repurposed before it's marketed, so that's quite interesting. So it was repurposed because it had in vitro activity, especially because they already looked at these drugs for, let's say, coronavirus #1, the MERS virus. So they had a little bit of experience with that. So they thought, okay, let's try and see whether this drug may be active against COVID-19. So this is how Remdesimir looks like. It's a kind of prodrug that needs to be activated in the body. So it's first transferred into a nucleoside and then it's phosphorylated. And in that stage, it's an inhibitor of the viral RNA-dependent RNA polymerase. And I put in some pictures to make it a little bit more easy to understand what's happening. So here, the small pink molecule is Remdesimir, and it actually terminates the replication cycle. So when that happens, there's no replication anymore. So they tested this drug, and you see in this graph on the right side that there is a nice correlation between increasing concentration of Remdesimir and the inhibition of the replication. And when they looked at the toxicity of the drug in the in vitro system, there's no clear correlation between potential toxicity and the concentration. So this all seemed good to go. So they also looked at animal models. In this case, they looked at a monkey model where they infected the animals with SARS-CoV-2. And what happens is that this monkey model, these animals develop disease very rapidly. So already after 12 hours of inoculation, they have to start the treatment. So that's a little bit different in humans. So they did some remarkable findings. So when these monkeys responded to treatment, this did not reduce the virus shedding. So you may seem I'm responding to treatment, but you're still infectious to others. So that's something to keep in mind. They did not have access to analyzing the drug levels in the respiratory system. So we don't know whether those levels were, for example, low. So that could have been in relation to the shedding. This could potentially require a different route of administration to reduce transmission. You can imagine that if you have a larger concentration of the drug at the site of infection in the lung, that you can reduce the spreading. Although we know that the spreading of SARS-CoV-2 is not only related to droplets, but also to touching and other types of transmission. So it does not prevent everything. But at least it showed some promising results, and that's why it's also, of course, studied in humans. So the first, let's say, large publication on Remdesimir was the New England Journal, of course, because it was exciting and new. Like in the other studies, we have patients who have problems with breathing, low oxygen saturation, mechanical ventilation, and of course they look at follow-up outcome and what's happening to these patients. So this is the first result of their compassionate use program. And if you look at what the company did, they launched several types of studies around the same time. And this compassionate use program was run alongside the development of these clinical trial applications. So on the first graph, you can look at the differences in response in relation to whether patients received non-invasive or invasive oxygen support. In the other graph on the right side, we can have a look at the effect of age in relation to response. And of course, we see that patients who are younger and do not require invasive breathing as much as the other patients had a better response. And that, of course, is difficult to distinguish between the fact that these patients all received the drug. So we definitely need a placebo to compare the actual response to the drug. So that's why, of course, they did a trial with a placebo. They randomized patients to Remdesimir placebo 1-to-1 ratio, and they performed a nice stratification based on severity of disease. So they included patients with more severe disease requiring mechanical ventilation. They also included patients with mild to moderate disease. And of course, they also stratified by study site. If you go through the lengthy protocol of this study, you could notice that there are different situations at each site. Some hospitals had local policy with hydroxychloroquine or other types of treatment. So it's in those situations when a site was included in the study, those patients actually could still use those hospital protocolized recommended drugs. So that's again a situation where it's more difficult to understand the benefit of a single drug if you give a complete cocktail of drugs. This study was designed at discovering a difference in recovery. So they required 400 recoveries to see a difference of approximately 35% in recovery rate between placebo and Remdesimir. So this all showed some favorable results for Remdesimir, a shorter time to recovery with a median of 11 days versus 15 days on placebo. One of the things is that this was a preliminary results. So what they found, they had sufficient number of recoveries for their primary endpoint, but unfortunately they did not have all the follow-up in all patients. But because it was a very urgent medical need to share the results were published at an early stage. So about 70% of the patients were fully evaluable and the other patients only for limited parameters. But the basic conclusion from this study was that patients who were hospitalized with COVID-19 and COVID-19 was indeed confirmed by lab tests and required oxygen therapy, and they benefited with a shorter time to recovery. One of the conclusions, however, was that antiviral treatment alone is not likely to be sufficient. They performed another study as well, where they looked at the days of Remdesimir treatment. So they randomized 5 versus 10 days of treatment in patients with severe COVID-19 disease. So again, the virus had to be confirmed. They had a requirement for oxygen saturation. And then they randomized 5 versus 10 days. And they looked at clinical status at day 14, time to clinical improvement, recovery, and death from any cause. So again, there was a positive response. And of course, this one is a little bit more difficult to understand because there was no placebo included in this trial. So they could only look at the difference between 5 days of treatment and 10 days of treatment. And the distribution in clinical status was not that different. There was no significant difference. And there were some things that were commented on this trial. There was a difference in baseline characteristics. And given the urgent medical need for hospital capacity, patients were allowed to be discharged early to free capacity for other patients. So these are all things you would normally not see in a well-designed trial. This is all adapted to the local situation, to the pandemic. And that's why, and I think you see it across all COVID-19 trials, that they all have some minor mistakes or imperfection, things you would normally not see in studies published in the New England Journal. After all these studies, there are still many questions that remain unanswered. We have the incomplete phase 3 study. We're still waiting the final results. We're lacking data on specific situations, patients with renal function problem, hepatic impairment. These were excluded from participation in the studies. They also didn't include PK and PD in the analysis. And we know from many trials that you need a sufficient amount of drug exposure to inhibit viral replication or kill bacteria, etc. And it would have been good, especially if you talk about critically ill patients, and likely there would have been certain pharmacokinetic variability, and that they included such information in the evaluation. And there were also comments on these trials, and one of them was very interesting. When do you start treatment? So when COVID, when you are severely ill, often that is when you're already a little while infected with the virus. So the sooner you start with treatment, the sooner you can inhibit viral replication. And these patients in the trials were severely ill, so there was likely already massive replication of the virus and the onset of the severe inflammatory conditions. So are these the perfect patients to test this drug? And also the situation about the route of administration, does inhalation reduce transmission? We don't know, it's something that has to be tested, of course. And of course, the comments already made earlier about the design of trials during the pandemic, with all the difficult situations, shortage of staff, shortage of hospital beds, shortage of ventilators. And this all complicates the evaluation of a new drug. All these studies were, however, translated into practice guidelines. And an interesting paper was published in the British Medical Journal, and their number one recommendation was to suggest remdesivir rather than no remdesivir for severe COVID-19. So better safe than sorry, especially because this was a not very toxic drug. They do provide a whole bunch of recommendations for future research, to look at time to clinical improvement, mortality, the need for mechanical ventilation, hospitalization, quality of life. They also mentioned that we need to look for the optimal dose, the time of starting treatment, and the duration of therapy. Or, and this is interesting, should it be given alone or in combination with other drugs? So what next? If we discuss about combination therapy, there was a very interesting paper recently published in Nature Communications about a protease inhibitor, GC376. You see the molecule below. It seems like a very simple molecule, but the amazing effect is that when you combine it with remdesivir, there is a complete inhibition of viral replication. And this makes sense because you inhibit a viral replication at two different points in the replication cycle. So it makes sense that the benefit of this is more substantial. We see that also in other viral infections, that if you provide combination therapy, you are more effective. Of course, GC376 is not entering the market yet, so we have to wait a little longer, but I think this is very promising to explore further. Another thing is the drug itself. Remdesivir is a prodrug. It needs to be converted, and of course there can be a little bit of variability in the efficacy of conversion in the different patients. So that's why they looked at modifications on this molecule to make it not only orally available, but also more stable in the human body. So it's better available for cellular uptake and inhibition of the viral replication. And on the lower part of the slide, on the left slide, you see the different modifications that they tested. And indeed, if we look at the right part of the slide, you see the efficacy of the different compounds in inhibition of the viral replication in an in vitro system. And indeed, these other molecules seem to be far more active than remdesivir itself. And so I think if we look at these two new approaches, having a drug that is more stable, does not require all the extensive activation steps, and combine it with another active drug, I think we have a bright future for treatment of COVID-19. What we do need to understand is, I think, the cost effectiveness of COVID-19 treatment. We now start treatment when patients are already in the hospital, but what happens if we can initiate treatment in a very early stage? Let's say when you have received a nasal swab shown positive for COVID-19. And what happens if we then initiate treatment to prevent replication of the virus, reduce viral shed, reduce potential escalation of disease? Of course, we need to treat many, many patients because we know that only a few % of the patients end up in hospital. But we can do the calculations whether that could be cost effective. Of course, we need to do further dose optimization of this drug. And for that, it's important to look at the pharmacokinetics of the drug, the concentrations at the site of infections. And I think if we look at the two more recent evaluations, so with new analogs and combination with other antiviral drugs, I think these are the next steps for Remdesimir in the battle against COVID-19. So if there are any questions, I'm happy to take them.
Yeah, there's a couple there for you. You talked about whether it was affordable then. Is it expensive to make physically as well? Or you talking about cost effectiveness there in terms of giving it to everybody and whether you see any effect? Is it an expensive drug for us to make?
I'm not familiar with the production cost of Remdesimir, but I think it's a small molecule, so likely it will not be very expensive,
Okay.
But that's just an assumption. But still, it's about what the actual drug cost is going to be and who is going to pay for the treatment. So it's all about the balance. If we have to treat, let's say, 100 patients with Remdesimir to prevent one from ending up in the ICU, it's just a balance of costs and qualities of lives, etc. And so I think there will be more studies in this area in the next couple of months, looking at treatment strategies and whether they are cost effective or not.
And the plan would potentially be to do those treatments earlier on than the other two drugs we talked about. Really, that would be the plan.
Yeah, I think it makes sense. If we look, for example, at oseltamivir in the past, we noticed that for that drug, you needed to start it early to see the benefit in patients with the flu to prevent, let's say, patient escalating to critical illness. So yeah, to me, it makes sense to early intervene in viral replication to prevent progression to severe disease. I think we see that across all viral infections. Of course, we don't know yet which patients do get a severe disease and which patients don't. So if we can add an additional test to the nasal swab, so you're positive for COVID-19, but you have this gene, so likely you will not escalate severe disease, you don't need the drug. So there's a lot of research opportunities to,
Yeah. Okay. Cool.
Treatment and diagnosis. Yeah.
There was a question just come in as well about that. There was excitement and increase in the share price of the company with the results so far. There's a question of whether it is the miracle cure we're all led to believe. Is it been overhyped? Do you think? Has everything been overhyped because everything's on the news all the time?
Yeah. I think it was a clever strategy of the company to repurpose these drugs for COVID-19, considering all the situations we're in now. We all see that it's not a miracle drug yet. It shortens time to recovery. it's not the drug that is a miracle cure yet. We understand a little bit too little about which patients are going to respond and when to start treatment at what dose. So there's still things that we need to optimize.
Cool, no worries. Well, what we'll do is if we we'll stop the sharing. If everybody wants to turn themselves off mute. Natalie, there was a question that came through that you wrote an answer to. Is that anything you wanted to talk about live as well, or was it all captured in the answer there for everybody?
And I'll more than happy to repeat the question and the answer. So I think the question was just, it was unclear. The question was to say that what are the natural levels of interferon in patients who do have COVID? Are they kind of naturally lower? And I just wanted to highlight that the immune analysis that I had spoken about, it just showed that patients who ended up developing the critical or the severe form of the disease, in comparison to those who only developed the mild form of the disease, they were observed to have a unique phenotype which included a lower level of interferon in the blood. And so that's kind of suggestive of that for some reason these patients who did go on to the severe form of the disease, the virus or the corona in those particular patients was able to somehow develop a strategy to numb down that natural interferon response and therefore cause a lower levels of interferon in the blood, in the body. So that's just, I hope that clarified the question.
Sounds great, sounds great. We've got a question come in and open to the floor here, really about understand the use of placebos, but you know, what about the ethics? You know what I mean? You've got a treatment that's found effective and you're giving some people a placebo and some not, and we're seeing if they're dying in beds and stuff. I know I'm overplaying it a bit, but has anything been anything done about that? Do they swap them over to the active from the placebo or anything like that in the, you know, toward the end of these trials? You know, how's it been? You said like the COVID trials aren't normal trials, are they? So
I can comment a little bit from the studies that I were looking at for dexamethasone. I was a bit concerned about that as well when I was looking at some of the data, but the ones that I came across, they weren't actually using placebo. They were using what they termed as supportive care. So just a protocol that they had established at the time to help patients with the management of COVID. So included, I'm assuming, a number of medications, a number of therapies as well. So I don't think patients, you know, some of them would be allowed to get a drug that's showing great benefits, then others sort of being withheld from that drug. But I think also Jan had something to comment as well.
Yeah, it's of course based on what drug we're evaluating and whether there's access to that drug or not, and what is the status of a specific drug. So with the Remdesimir, we're talking about an experimental drug. We don't know about efficacy and safety. We have some animal data, and we have some in vitro tests that show a nice sigmoid curve of response. We have these curves from many drugs who never end up as a treatment. So still, always the first trial should include a placebo to compare the effect versus standard of care, because all these patients received standard of care at that moment. Even some received hydroxychloroquine or lopinavir or whatever, because it was already in hospital protocol. And so they did take that into account, and I think even more than with other trials who were not COVID related, because they also, if you look at normal studies done by pharmaceutical industry, even some of the licensed medications for a specific disease are not allowed in a clinical trial to better understand the impact of the drug itself and create the robust evidence to prove that a drug works or not.
Yeah, no, that's fair enough. That's fair enough. Let's have a look at some of these. Are there associated IP and supply issues with the drugs at all that's going to cause problems?
With which drugs?
Well, whoever wants to answer first, really, I suppose. My questions are generic. I apologise.
Yeah, there is for Remdesimir, there's a designated program because it's released early on the market for medical need.
Mm-hmm.
You need to fill in all the forms to get access to the drug, and of course provide information on how the patients, of course, responded to that drug before it's officially approved after all the clinical trials have been performed and evaluated by regulatory bodies. And yeah, in that stage, there's always a shortage, and it's difficult to get access, and it's all regulated and requires a lot of paperwork.
Yeah.
But that's inherent in the situation. Yeah.
Yeah, that's cool. Natalie, were there any issues with interferon-beta in terms of those things?
So as far as I'm aware, it's not really, I guess, I know in our hospital, we probably do keep it, but it's kind of not part of the, our formulary, which is kind of the usual medications that are readily available to patients. And it's just because it's not really something that's, I've seen a lot of patients usually are on, and perhaps because of the demographics of the patients who are admitted in our hospital, not a lot of them do have, I guess, MS or other forms of motor neuron disease. But in terms of obtaining it, I guess there's no, I don't think there's any particular major issues, although it's not something that would be readily available for the treatment of COVID. So I did try, in preparation for this particular talk, contact a few of the companies that actually manufacture and keep interferon-beta in Australia. And it was not, the information that they provided me was that they pretty much had nothing on its usage in COVID. So it's still in its kind of preliminary stages in terms of a therapy for the treatment or as part of the treatment of COVID. And certainly accessing it, I guess, for MS is definitely not an issue, but I don't think it's very well established in terms of ease of access particularly for the purpose of COVID therapy. So I think that might pose a few problems if I was to, I guess, try to obtain it for a particular patient in our hospital, for instance, and just to say that it's actually for COVID. Again, because we don't really know yet exactly what the dosages are. The doctors aren't very familiar with what they would prescribe to begin with. So I think that might pose a bit of an issue, but it's not something I've come across yet. So not very popular just yet.
And on dosage levels for yourself and Renee and Jan-Willem as well, you're not actually just specifically just giving the same dosage you would give to someone with MS, because obviously safety then is something to consider, isn't it?
Exactly, and it's interestingly the clinical trials that I've looked through and I've reviewed, they don't have one particular set of regimen that they all stick by. It does differ, the dosage. They all generally are subcut, and it is generally kind of for a 2-week period on alternate days. In terms of the frequency, that's similar, but the dosage itself does vary, whilst not massively, but it definitely does vary to what's established already for MS. So yeah, there are variants there, yeah.
And Renee, you mentioned, I think, that for you that the treatment was very similar to how it would be traditionally used. So no real differences there. Is that fair, or?
In terms of duration for use, yes, it's still quite limited to that short period to avoid the I guess, more concerning side effects of corticosteroids. But on your point previously about supply, I did mention in the presentation that after the preliminary results of the recovery trial were published, showing promising results and actually saving lives, the production of the medication worldwide actually went up. And in dexamethasone, it's a drug that's been readily available for many, many years. So something that's easily accessible and quite affordable also.
Excellent, excellent. There was a question, let me just read it quickly to make sure I read it correctly. So adding to the question earlier regarding the inclusion of hydroxychloroquine, since it was added to all 3 groups, was there any significant difference in outcome between the 3 groups? If it did, how could you say if it were due to the interferon or hydroxychloroquine? Does that make sense? That would be for you, Natalie. Does that make sense?
Just wondering what the 3 groups is referring to. So a lot of the studies that have been concluded that I've discussed, it's either the patients received the national protocol, which included hydroxychloroquine, and that was both the treatment and the control group. And the only difference was that the treatment group also had the addition of interferon-beta. So any kind of difference that was shown in terms of the primary or the secondary outcome measures would be as a result of adding interferon-beta to the treatment.
Yeah, okay, yeah. Fair enough. There's a lot of the combination therapies, like you said. It's not like you're just giving them one and not doing anything else, is it? So that's all good. That's all good. No, I don't have many other questions. I don't know if you had any questions for each other. I'll just have a look at what we've got. We've kind of answered them. They're about kind of symptoms and look. I suppose one magical question. You know, is it going to appear on the side of the box saying it's treatment for coronavirus anytime soon or COVID on any of these drugs? Do you think? Or when I say soon, we all want it to yesterday, but
I think everyone is trying to focus on the vaccine now. So until that happens, I don't know about how quickly these other medications will kind of be established and will have these stuff appearing on the box. So I think the vaccine is priority at the moment. But in the meantime, probably not for interferon-beta from what I could find. Maybe for dexamethasone or remdesivir, maybe dexamethasone mostly. I think that's definitely something that is used currently in hospitals. I know for patients who are presented with COVID. So perhaps more medications than others.
So it has started being included. Sorry, Jan-Willem, you carry on. I'm just interrupting like I always do.
I wanted to mention only, let's say, is the name of the disease going to be in the label of that particular drug? And I think that is a good question, because we see many repurposed drugs, off-label drug use, and there is a company who needs to apply for that particular indication, for that particular drug, to be licensed and officially approved. And I think none of the generic pharmaceuticals are interested to put in all the paperwork for dexamethasone to pay for the licenses in all these countries. So I don't think there's going to be an official licensed indication for dexamethasone for COVID-19. It will be in all the guidelines of all the professional societies. That's number one, I guess, but still it's not, it will still be off-label. And I think therefore that only Remdesimir, which has a pharmaceutical company actively seeking regulatory approval for this indication, will get the labeled indication COVID-19.
Fair enough. Did you have anything to add about dexamethasone, Renee, on that?
No, I think it was clear what Jan was saying. It takes a long time to gather the data required in order to extend an indication of a medicine. A lot of time to compile, a lot of time to submit, and a lot of time also for the regulatory bodies to evaluate in all the different countries. So even if that was the case, we're talking at least a year and a half. So a long process, but I also agree with Natalie as well. The vaccine's a priority at the moment. So I think the spotlight's definitely on that.
So I'm guessing that does make it difficult to carry on doing the research and the clinical trials and things, because obviously we're putting all our eggs into the vaccine basket, aren't we? So, which is fair enough, you know, prevention better than cure, as they say. So,
yeah, but there will still be room for treatment.
Of course.
For other diseases as well. There's still patients getting the disease or don't want to be vaccinated or whatsoever. So.
Yeah, that was just about to say exactly that. So
what do you mean? There's nobody who doesn't want vaccines. What are you talking about?
So we don't even exactly. We don't even know. You know, the vaccine, of course, when it's very new onto the market, there are many things that also will remain hidden until, I guess, the future post market surveillance. So, you know, besides that aspect of it, I think that there will definitely be room for active treatments as well for patients who will still get it. I'm assuming even if they get vaccinated, maybe mild to moderate form. So we'll just have to, I guess, wait and find out.
Yeah, of course. Look, and I was about to end it then. We've got one more question and then we'll finish up. We've got about 5 minutes. So, oh no, I've got two. Oh, one's about Trump. We'll see if we ask that one. So what is the development/registration status of the compound, the Jan, that you mentioned as a combination therapy with Remdesimir?
Yeah, the combination therapy is not near anything yet. These are, say, in vitro experiments, and they're designing the new molecules. So that will take a long time before that enters the market. But I think it's very promising. So they should continue with their efforts to optimize the molecule, because there will be more these types of diseases in the future. It's not over after COVID-19. Perhaps you get COVID-20 or 21 or whatever. Like we had MERS first, and now we have COVID. So, yeah.
Yeah. Fair enough. On that note, I think we'll wrap it up. I think that's fantastic. Thank you all for speaking on your chosen subjects. That was fantastic. I hope everybody who was listening enjoyed that. And yeah, just thanks again. And see you all soon. Take it easy.
Thank you. Thanks, everyone.
Thank you.
See you.
See you.
Bye.